Great. Well, I was really chuffed to be assigned this section because for me, creating order amongst the chaos is a fundamental process that underpins many of the clinical encounters that we have, certainly in the pre-hospital setting. And I think one of the joys of pre-hospital care is working to optimize the environment that we find ourselves in, creating strategies and plans to overcome the challenges that present to us. But it's not just the pre-hospital setting. In-hospital care can be equally demanding with busy, noisy departments, tight resus bays, and stretched resources. So wherever we are, we need an approach to advanced airway management that gives us consistent and replicable working conditions that brings familiarity and control. We can then take that blueprint and we can apply it to any of the unique situations we find ourselves in. But we also need to remain flexible enough to adapt that blueprint when necessary. Plus, we've got to think about some of those wider issues that might affect us. So I guess a natural question to ask here is, why bother? Why not just crack on? Well, when we're preparing for an intubation attempt, we really need to consider all the factors that might influence the success of the intubation attempt. And we need to strive to optimize every one of them prior to the first attempt. So this is about safety, efficiency, and ultimately speed. And speed tempered with safety is absolutely vital in our emergency airway management. And I guess one clear driver for that is the NICE guidance on major trauma, which says that we should be performing RSI as soon as possible, and certainly within 45 minutes of the initial call, and preferably at the scene of the incident. Okay, so let's start out by thinking about some of those wider issues that might impact on our intubation, because while environmental pressures might be more of an issue for pre-hospital staff, there's definitely crossover into the ED as well. And I think one of the most common challenges we face is space. No one collapses or has a traumatic incident in a ballroom. Well, I mean, maybe they do, but it's much more common that we find our patients in a busy living room or a cramped office where space is at a premium. So we've got to work smart and either find space or create space. Now, ideally, we want easy, uncluttered, 360-degree access to the patient to allow us to move around safely, but also deliver our interventions without being confined by the environment. But 360 access is not always feasible, particularly in the location the patient's presented. So if this is a cardiac arrest, then at a minimum, we need to create space around the patient's head. But, don't discount sliding them into a more open space. If this is an RSI, though, then we do have the benefit of being able to move the patient from their location into a far more optimal one. Now, ideally, we're looking for somewhere private, secure, warm, well-lit, and spacious. I know, a fairly significant list, but it's always good to have something to aim for. And something else to consider, if all that wasn't enough, is that ideally we'll do the RSI on the ground floor with an easy trolley push to the ambulance. We really don't want to have to face a long and complicated extrication with an intubated and ventilated patient. Now, if the patient is outside, then the weather definitely plays a part in selecting where to undertake the intubation. In particular, I'm thinking about the sun. Yes, something slightly alien to our UK colleagues, but if you do happen to see it, then make sure it's behind you. This also goes for bright lights in hospital, because if you look towards the bright light source, your pupils constrict. And that becomes a problem because when you look into the much darker oral cavity, that means that your ability to identify those vital glottic structures might be hampered. I guess the only issue with having the sun behind you, certainly when using a video laryngoscope, is that the glare on the screen can be a real menace. So having a blanket ready to hold up and protect the intubator and their view of the screen can be hugely helpful. Now, obviously, rain and wind always provide a bit of fun too when you're trying to keep your kit dump in the same place and in good order. So clearly finding some shelter can be really valuable, but if you can't, then also the fire brigade can be really helpful here, and they can hold up or rig up some large tarps over your work area, and that can be pretty effective. And I guess the last thing to consider is that noise can be a huge issue for the safe delivery of an advanced airway procedure, mainly because it's a massive barrier to effective communication. But there are some studies that have even linked loud sounds to reduced motor skill performance. So get non-essential equipment turned off, move non-essential staff members out of the room, and ask those present to remain silent as you start working through your checklist. Okay, so we've touched on the idea of a kit dump already, so let's focus in on that because this is a really essential component of that blueprint. Now, as I've alluded to in the previous section, when we're setting up for an RSI, the kit dump's almost invariably established away from the patient. And as well as allowing you to choose the optimal location, that means you're also away from the distractions that come from being around a patient who's having active clinical care. And in contrast, if you're managing that cardiac arrest, then you're pretty much forced to set up your kit dump next to the patient's head. This is never ideal, as you definitely find people wandering through your carefully prepared kit dump, so any way of protecting it is fair game. Now, what you lay out and in what order is going to be determined by your organisation, and that is important because standardisation is vital if we're looking to improve safety and efficiency. Everyone in the organisation needs to train and use the same kit dump layout to maximise its impact. Sometimes people use shadow boards, and that's where you lay out equipment onto its own printed shadow. And I use that in my retrieval role, and I really like it. Not only is it a cognitive aid, but it also empowers other team members to challenge me if a shadow doesn't have an associated item above it. And I guess an extension beyond that is something like the scram bag, where the majority of items required for the intubation are already laid out in the bag as it's opened up. And another really key part of the blueprint for advanced airway management is standardized positioning for each team member. Assigning roles which are associated with a pre-planned position is fantastic for improving our human factors because everyone understands their part in the intubation and they're already in the ideal place to undertake their aspect of the intervention. Now, you're not always going to need all the different roles, and that's part of being flexible with your blueprint. So another very well-trodden path in standardising our approach to intubation is the checklist. Now, these cognitive aids aim to reduce the risk involved by providing a structured approach, ensuring crucial elements aren't forgotten whilst allowing the team to reduce their cognitive burden and liberate some bandwidth. But checklists aren't a golden bullet, and they certainly divide opinion. There was a large systematic review and meta-analysis from 2020 in anaesthesia, and that found that checklist use wasn't associated with decreased mortality. That was their primary outcome. But it did reduce the incidence of hypoxic events, and when we look at the detail behind this, there were relatively few studies available for the analysis, and they covered loads of different practice areas and patient groups. And actually, when we delve into the subgroup analysis, there was definitely a trend towards benefit from checklist use across several patient outcomes in both the ED and paediatric populations. And checklists have previously been shown to improve outcomes in multiple other practice settings within healthcare. So it really does seem to make sense that they would be beneficial for emergency airway management. But for checklists to achieve what we want them to achieve, they have to be well written and well executed. One of the concerns that have been levelled at checklists is that they can result in delays in intubation, and I guess for us with our critically ill patients, a delay in securing the airway could definitely be detrimental. But is that the fault of the checklist? A well-designed checklist should cover all the essential safety critical points and cut out unnecessary steps. And another risk of checklist use is the idea of checklist fatigue. So how do we overcome that? Well, I think we have to stop viewing our participation in the checklist as a passive process, and we have to become more actively engaged in them. We often talk about the challenge and response method with intubation and pre-hospital anaesthesia, and this not only speeds up the checklist process compared to a check and do method, but it also increases the rigour of the process. One person reads through the checklist and challenges another to respond. And we're going to talk more about this in the airway assistance section. So I guess finally in our considerations before intubation, we need to discuss our airway plan. Clearly we want to intubate the patient, but what happens if we can't? A clear verbalization of our planned steps is absolutely vital so that everyone in the team shares the same mental model. And when it comes to models, really we've got two key options: the Difficult Airway Society failed intubation algorithm or the Vortex approach. Now, on the face of it, they've got some similarities, but actually their ethos is very different. Either one works well, but whichever you choose, you and your team need to be familiar with it and know which one you're going to be using prior to the intubation. Now, for the detail behind this, it's worth taking a listen to our episode on the front of neck access, but in summary, the Difficult Airway Society advocate a very linear and sequential approach to the failed intubation. Firstly, intubating, and then if that fails, inserting a supraglottic before trying a 2-person bag mask ventilation if the supraglottic's unsuccessful. And if all of these interventions fail, then we undertake front of neck access. Now, I think this can be a really useful algorithm to follow, and certainly its linear and didactic approach can definitely help with some of the cognitive load and the stress involved in a failed intubation attempt. However, some clinicians prefer the more flowing approach of the vortex method. Now, this proposes that intubation, supraglottic airway, and bag mask ventilation are lifelines that enable oxygenation and ventilation. Yes, identical to the Difficult Airway Society, I hear you cry. Well, yes, but the vortex isn't prescriptive about how you use the lifelines. Each one can be used a maximum of 3 times, with at least one attempt at each being undertaken by the most experienced operator. But the order in which you use the lifelines is at the discretion of the clinician. The endpoint's the same though. When you fail all 3 lifelines, we end up at front of neck access. I think for me, the vortex feels like a more adaptable and appropriate way to manage our complex and varied emergency intubations. And there are also some really nice elements woven into the vortex approach to reduce the cognitive burden of a failed intubation. Things like identifying the front of neck access kit after failure of the first lifeline, then putting it onto the patient's chest after failure of the second, and then opening the kit and using it after failure of the third. Great stuff.
Okay, well, just thinking a little bit back to that environment pre-hospitally, would you, and this is a weighted question, would you consider intubating in an ambulance, James?
Yeah, it's a good question, isn't it? Because, they certainly seem like a very appealing option from an availability and a conveniency perspective, don't they? But actually, many systems discourage anaesthesia in an ambulance. And, there's definitely good sense behind that. It's pretty challenging, if not impossible, to get 360 access to the patient. And you might have trouble changing the height of the stretcher if it's locked into the floor. And there might be nowhere suitable to set up your kit dump. But having said all of that, I did say that we need our blueprint to be adaptable, and I really don't think there are too many black and white rules in pre-hospital care, and, I think that's what makes it fun. Although, maybe I'm just trying to justify my own practice, because there are definitely times that I have used an ambulance for an intubation. I guess examples are like when it's been blowing a gale and raining and you're at the side of the motorway with no other shelter around you, or if there's a hostile crowd outside. Or I even did one actually on bonfire night with fireworks going off all around us. I felt like we were in mortal danger if we stayed outside. So, in answer to your question, I think we can do it, but it does have risks, and it has to be a considered decision, weighing up the pros and the cons, rather than being an accepted deviation, if you like.
Yeah, no, that's fair enough. And well done for not mentioning the fact that you definitely want to be inside the ambulance so you can sit down on that comfy seat at the airway end.
No, absolutely nothing to do with it. So, actually, Simon, I have a question for you, if that's okay, because I guess in that section I have talked a lot about pre-hospital considerations, but I feel like there's a lot of crossover from those into the in-hospital setting. And I just wondered what your thoughts were around controlling the environment when you approach an RSI from the ED perspective.
Yeah, there are loads of things, I think, to draw across from pre-hospital airway management into in-hospital that we could learn, actually. And I think one of the main things, actually, is that you might consider a hospital to be this really quiet, safe environment. But actually, just like you've got to manage the crowd in a pre-hospital environment, you can get a huge amount of people coming into resus when there's an interesting case to be dealt with. And I think making sure that you limit the number of people around that bed space to the people that actually need to be involved in that management is really important, because having that space creation can actually be really dependent upon the number of people that are in there. The other things that are probably worth mentioning is where the kit is, especially from an operator 2 perspective, and this will depend on your design of your resus, but ensuring that the kit is all on the correct side, the monitoring is turned so that you can see it, and ergonomically it's set up the best way possible, including that the VL screen is really drawn in to the side of the patient if you've got one of those ones on a trolley. And then I guess finally, those kit dumps pre-hospitally, often using a shadow board. We don't necessarily always have those in hospital. Obviously, that's something that we could change, but that's going to take a bit of time. But for the next case that you've got in hospital, I think making sure that your kit dump's really nicely prepared from an operator number 2 perspective. If you haven't got that board, having them laid out in sequence, so you go from one bit of kit to the next in the order that you'll need it, is a really good way of remembering the kit that you'll need and then being able to deliver it with real ease and knowing exactly where it is.